questions to Dr. Lee as well. Okay, and whenever you're ready, Dr. Lee.
Okay, well, let's jump right in because I have a lot to talk about. So thank you all for joining me today. I'm really happy to be here and talking about a subject that I'm very passionate about, and I know it affects a lot of people. So I hope you'll learn something from today's talk. And it's not an all-inclusive talk. You know, I could talk for hours about this subject. So these are the topics I thought I would cover. At least give you a general overview so you have information about dry eye that empowers you to understand more about your specific condition and what you can do about it. So these are the questions we're going to address today. So 1, what is dry eye? 2, how is dry eye diagnosed? 3, what causes dry eye? And 4, how is dry eye treated? But let's first start with a little quiz. And don't worry, it's not really a quiz. Okay, so relax. But this is why I asked you to have a paper and something to write with. Okay, so on your paper, I want you to write numbers 1 through 12. And let's get started. Okay, so for questions number 1 through 5, I want you to answer this question. Have you experienced any of the following symptoms during the last week? And you're going to rank this on a scale of 0 to 4, with 0 being none of the time and 4 being all of the time. So the first symptom is eyes that are sensitive to light. And the second question is eyes that feel gritty. The third one is painful or sore eyes. And the fourth is blurred vision. And the fifth is poor vision. So write a numerical score for each of those 5 questions, depending on how often you have experienced that particular symptom in the last 1 week. Okay, so now let's do questions 6 through 9. Have problems with your eyes limited you in performing any of the following during the last week? Now, if you don't normally perform that activity, you can pick not applicable, but just keep track of what you answered, what you didn't answer. So again, on a scale of 0 to 4, with 0 being none of the time, 4 being all the time, how often did you have problems performing this task because of your eyes? Reading, driving at night, working with a computer or a bank ATM machine, and I would add to that a phone or a tablet. And number 9 is watching TV. Okay, so numbers 6, 7, 8, and 9, either write a numerical score, or if, for example, you don't own a car, so you don't drive, you can write not applicable for that. All right, and our last set of questions is, have your eyes felt uncomfortable in any of the following situations during the last week? Again, on a scale of 0 to 4, and you can pick not applicable if this condition doesn't apply for the last week. So 10, windy conditions, and today's pretty windy. 11, places or areas with low humidity or very dry. So if you live in Southern California, we do have low humidity. 12, areas that are air conditioned. Well, it's supposed to be the middle of winter, but maybe over the weekend when we hit the 80s, 90s, maybe you turned on the air conditioning in the car or something. So again, if you experienced no problems with your eyes feeling uncomfortable, you would rank 0, all the time 4, so on. Okay, so at this point you should have 12 answers, and if you pick not applicable, that's fine, but go ahead and calculate the sum of all those 12 answers that you put, and there's no rush. I'm going to give you a little bit of time to do that, but we're going to come back to this. Okay, so We are talking about dry eye today. It is a very common problem, and if this is something that you suffer from, you are not alone. It affects anywhere from 14 to 33% of the population in the United States, depending on which survey and what definition you use. But what is dry eye? So this is the first question I told you we would answer today. So this is the official and most updated definition of dry eye based on the tear film and ocular surface working group. In 2017, a bunch of experts met, and this is the definition that they have put forth. Dry eye is a multifactorial disease of the ocular surface characterized by a loss of homeostasis of the tear film, and that is the most important phrase in this definition. It is accompanied by ocular symptoms in which tear film instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities play etiological roles. So this is a mouthful, but let me break it down to you to say, this disease is not caused by one thing. There are multiple components at play that make the tear film function in a healthy way so that you have a balance constantly of all the different components. And when there is a breakdown of that delicate balance, you can get all kinds of symptoms like the ones in the survey that we talked about just a minute ago. And you get tear film instability and inflammation, damage to the eye, and effects on the nerves. And we'll talk about each of the components of this definition as we go on. But the symptoms that you may or may not feel can include one or many of the following: scratchiness, feeling as if there's something stuck in your eye, pain or soreness, redness, discharge, heaviness of the eyelids, like it's so hard to open them, light sensitivity, eye fatigue, and blurred or distorted vision. These tend to be worse at the end of the day, worse with extended computer use or reading, worse in windy weather or when the heat is on, when the air conditioning is on. And it tends to be better after you've woken up from sleep. Although if you feel worse after waking up from sleep, we're going to touch on that a little later. Maybe better after you took a shower. So if this sounds familiar to any of you, then you're in the right place. But to continue our conversation, I want to put this into context of which anatomical part of the eye we're talking about. Okay, so in this cross-sectional picture of the eye, we are laying down on our back, looking up at the ceiling, and the light from the ceiling is entering from the top of your screen going down into the eye. We tend to talk about the different parts of the eye, like front of the eye, back of the eye. So this red square is showing you what is the front of the eye. So I am a cornea specialist, so I'm a front of the eye expert. And today what we're talking about is we're going to focus on the tear film and the cornea. So the cornea is a clear covering in front of the colored part of your eye. If you are a contact lens wearer, you're putting your contact lens on top of your cornea. When you have a normal cornea, you don't even know you have a cornea. When you look in the mirror, you don't even see the cornea because it's crystal clear. You see right through it and you look at the colored part of your eye and the pupil. Okay, now we're going to zoom in on the cornea itself. So the cornea is a 5-layer, very thin. It's about 0.5 millimeter in thickness, and it's very thin, very clear. But in front of the cornea, we have the tear film. So the epithelial layer of the cornea, or this most surface layer of the cornea, is bathed in a layer of tears all the time. Now, this corneal epithelium is very delicate. So I want you to touch your skin on the back of your hand, maybe touch on the bottom of your heel if you're not wearing socks. And you can feel that that is rough compared to put your tongue on the inside of your cheek, right? That feels different. That's because both of those tissues, your skin and the inside of your mouth, have epithelium, but they're different kinds of epithelium. So the epithelium that covers the entire surface of the eye, including the cornea, is more like the epithelium inside your mouth. It needs to stay wet all the time. So unlike your mouth, that if you didn't have to talk or eat, you could close it for several hours at a time. Us humans, we are so reliant upon our vision. We have to open our eyes for all our waking hours. So The tear film is really the only thing that keeps it moist and also protects us from infection. So the tear film provides oxygen to the cornea, and it's not just water, which we'll get into in a moment, but it has antibacterial, antimicrobial properties to it. There are properties to reduce inflammation so that you keep your cornea nice and clear. Now let's zoom in on just the tear film. So again, tears are not just water. It has 3 layers. So we're going to talk about these 3 layers. The first layer, or the layer that faces the outside air, is called a lipid layer. It's an oily layer that prevents evaporation of the next layer, which is the aqueous layer, or the thickest layer, and it contains mostly water. This also contains the oxygen that then diffuses into the cornea, and it contains all those antimicrobial molecules that I was just mentioning, and it will also wash away debris like toxic chemicals, allergens, and take them away from the eye. Also very important, it provides a smooth surface for light to enter as it goes into the eye so that you see clearly. So the lipid layer and the aqueous layer are the most important. There is a third layer called the mucin layer, and that helps the other 2 stick to the surface of the corneal epithelium. But if you have a problem with any of the 3 layers, you don't have it in good quantity, or the quality of that layer is impeded, or you don't have a good proper ratio of the 3, you can get dry eye. Okay, so we'll talk more about specific problems that happen when you have a problem with the lipid layer or the aqueous layer. More rarely, you can have a mucin layer deficiency. Okay, but before we move on, the eyelids are also very, very important. You can make enough tears, and you can make them in a good ratio of those 3 components that I just talked about. But if your eyelids do not work properly, they're not going to distribute the tears across the surface of the eye. So every time we blink, there's a movement of tears going from the outer corner towards the inner corner of the eye. And that washes the clean, fresh layer of moisture over the surface of the cornea and the entire eye. Also, when we blink, there's a little tiny bit of each of the tear components that come out of the glands. So in this diagram here, the green shows the lacrimal glands and the accessory lacrimal glands, and those make the watery or aqueous portion of the tears. And then the red squiggly lines are the meibomian glands, which make the lipid or oily layer of the tears. And what happens is each time you blink, a little bit of those are excreted, and the blinking action mixes them. Now, what is this on this blue thing on the left? I don't know if you can see my cursor. I think you can. Hold on, let me get the pointer. So this here is actually right here on the side of your nose. This is what we call the tear duct, but let me call it, for the purpose of today's lecture, the tear drainage duct, so it's not confusing. So think of this like the gutter on your house that takes the rainwater away from your house. You see, a normal person is making a little bit of tears on a constant basis. You're making them all day long, all night long, without you having to think about it. But what happens to all the tears that you're constantly making? A normal person isn't, having these tears fall down the surface of their face, like as if they're crying all the time. That is because the extra tears go down this duct and into the nose, from the nose into the back of the throat, and then you swallow them. And so if you've ever seen somebody who's crying, emotionally crying, or like children when they're crying, they sniffle, right? They're like, that's because they have all those extra tears are overflowing down their face, and they are going down into the nose. Okay, so I'm going into a lot of detail about this because, again, you'll see in a moment that problems with the eyelid can affect tear production and tear distribution. But no matter what problem occurs to lead to this, the loss of homeostasis of the tear film is that inciting incident that defines dry eye. So it could be because you're missing some of the lipid layer, And so then the aqueous layer is exposed, or you don't have enough of the aqueous layer and it evaporated, and then these epithelial cells of the cornea are just exposed to air. And if that goes on for too long, those epithelial cells will dry out and they can die or they fall off. And in severe cases, it can be hard for them to regenerate. And this is a cycle that can then lead to nerve damage or inflammation. And we'll talk about that a little bit more. But let's move on to, how is dry eye diagnosed? So normally when a patient comes into our office, we talk to them about their symptoms. And one way to evaluate those symptoms is with a questionnaire like the one we just did. We examine the tear film function and the tear stability, and this can all be done with this device called a slit lamp. I'm sure you've seen it if you've ever visited an ophthalmologist or an optometrist. We also use this device to look at the damage to the eye that has been incurred by the dryness. Okay, so you have the score from the 12 questions I asked you earlier. Now, if you add those up and you scored anything like from the teens above, look at this down here, you probably have some symptoms of dry eye. Okay, and certainly if you're anywhere in the moderate or anywhere near severe, you definitely should see an ophthalmologist, preferably someone who specializes in dry eye, to see what we can do for you. Okay, so if you didn't answer all the questions, you can just look at the number of questions that you did answer. So if you didn't answer all 12, like maybe you didn't read or drive this week, then you could find your score this way and then go down. Okay, and in a typical eye exam, what we do, let's see if this will play. Do you all see the video playing? No, right? Let's try again. Oh, here we go. Okay, so what's going on here is I'm looking through the slit lamp. I've applied a special dye to the eye, and that dye is an orange dye, but when I turn on this blue light, the dye shows up green. So what you see here down here, that is the tear meniscus or the tear lake. We also have one smaller one along the upper eyelid. And this is a very normal patient. So this is a normal looking tear lake. And I asked the patient to blink multiple times because I want to see, do the eyelids meet? And how far what do the tears look like when the patient blinks? And so this is a very normal exam. And again, we're looking for the tear lake or the tear meniscus, and that should be a certain height. And then this you did not see in the previous video because that was a very normal patient, but on the right is what you see, we call that the tear breakup. So that patient had such a nice, thin, normal layer of tears over the cornea that you didn't even see the green dye over the surface. But when you see the green dye, what we're looking for is, I asked the patient, blink, 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 and then open, and hold it open. And I am in my head counting to 10 seconds. And when I see the little blue areas light up between the green, that's how I know that the tears have broken up. So let's say I only count to 3 seconds, and I already see an area where the green broke up. That means this patient's tear breakup time is 3 seconds. What that means is if a normal person blinks every 10 seconds, that this person whose tear breakup time is 3 seconds, they're spending 70% of their waking hours with tears evaporating off the surface of their eye. So of course they're dry. Now, there are special high-tech ways to look at this if we want to, but usually we reserve this kind of thing for research purposes, but we can use these imaging techniques to very accurately measure how high the tear meniscus is, or we can use infrared imaging to create a map of not just when the tears break up, but where they break up. But that's not really necessary to make the diagnosis of dry eye. The other thing we look at, and again, this is just in the office using the slit lamp, is we look at the eyelashes, the eyelids, the junction between the smooth epithelium of the inner aspect of the eyelid and where it meets the outer skin of the eyelid. Here you see that's where the lashes are coming out, and you see these white dots right here. Those are the openings of the meibomian glands, those glands that make the oily layer of the tears. These are the little openings of them. And when I just push very gently on the eyelid, I should see a little bit of oil come out of those little glands. And what we are normally looking for is the oil to be nice and clear and liquidy like olive oil. And when we look at the lashes, what we want to see is that they're nice and clean, as opposed to, look here. So these eyelashes have some debris at the base of the lash. And so that's just like having dandruff at the root of your hair. And look at these glands. Instead of that clear yellow liquid that's more like olive oil, this is more thick, maybe cheesy, more opaque. And in severe cases, it comes out like toothpaste, like practically solid. It looks like a little string of toothpaste coming out. This particular patient, this one has eyeliner tattoo, but there are a lot of times when I ask the patient, oh, did you put on makeup this morning? They said, no, I wore makeup like 2 days ago. And I can see at the base of the lash, there's like a lot of old makeup caked on top of all this debris. So this usually something that I can see because I'm looking at it at high magnification, and patients don't realize that they have all of this on their eyelashes and lid margin. The next thing we always do is to look for how much damage has been done by dry eye. So I showed you before that you have the tear film, and then right under that is the epithelial layer of the cornea. That epithelium is very delicate and it loves to be moist. And when it dries out, those epithelial cells start to die. And these are pictures where we've applied a particular dye. So I already showed you that orange dye that with the blue light shines green. Well, these little dots on the surface of the cornea, each one of them is an area where the epithelial cells are dead or dying or missing. Similarly, here's a pink colored dye. Here's a green colored dye, but the idea is the same. When you have dryness on the surface of the eye, those epithelial cells are not happy and they can fall off. And you don't want this to be a continuous process because eventually you'll have more serious damage than this. So you can think of all of these spots as little microscopic scratches. And if you've ever had a scratch on the eye, like a corneal abrasion, you know that hurts horrifically. So no wonder patients with dry eye complain of things like burning and pain and soreness, because especially when you have this much damage on the corneal surface, it is painful. So we want to get that to heal. Okay, so I've showed you basically what are the things we look at to diagnose dry eye. There are some more other tests that we don't always do, and I'll show some of those to you too. So this is a tear film secretion test. It's called the Schirmer's test, and we just take a little strip of paper and we put it right in the corner of the eye and ask the patient to close their eyes, and the little strip of paper stays there, and we just leave the patient alone for 10 minutes. And after 10 minutes, we come and take that paper out and we measure how many millimeters the patient's tears have wet the strip of paper. So normal would be anywhere from 10 millimeters or beyond. And patients who have really severe dry eye, some patients make tears in the single-digit millimeters. We now have a test to test for inflammation of the tears. So what we do is we take this little device. It looks kind of like a pregnancy test, really, but we're putting the patient's tears on the tip of the test, and then we wait and we get this result. So the blue line, actually it's black in real life, is the control. So that should be there for as long as the test was done properly. Now the red line will only show up if you have inflammation of the tear film. Now to do this test properly, we do one on each eye, and it should be done with no drops having been placed on the eye for 2 hours. So a lot of times we can't do this test because the patients have put drops in their eyes on their way to the office or something. But when you test positive with this, it really tells me there's untreated inflammation on the surface of your eye, and your eyes are just bathed in these inflamed tears. So we really want to treat that inflammation. Another test that can be done is to test the tear osmolarity. What that means is how concentrated your tears are. So if your tears are more concentrated, that means that it's very abnormal, right? You have a higher concentration. That means you don't have enough liquid in the tear film. It also means something more towards the diagnosis of dry eye if this number constantly fluctuates. Okay, I was telling you about the meibomian glands that create the lipid. They live in the eyelid, both the upper eyelid and the lower eyelid. We can't actually see the glands that produce the tears. We just see the opening where the tears come out, and that's where I was saying it would either look like olive oil or in severe cases like toothpaste, right? But with infrared imaging, we can actually see the glands themselves. So this is actually a patient with severe dry eye, and this is her husband who kindly allowed me to image him for comparison. So you can see these are very normal, nice long linear structures. Those are all glands, and they're producing the lipid, and as the oil is made, they're going up, 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 and they come out of those little holes I showed you that are near the eyelash root. Well, hers, she has a problem called Sjogren's syndrome. We'll talk about that in a moment, but she has severe dry eye, and you can see some of her glands aren't producing any lipid, and some of them are like maybe truncated, but some of them are very, very short. And we think some of her glands are just non-functional at all. Now, this is a device I use for research purposes. It's called confocal microscopy. I'll just really quickly show you. It can create these nice, beautiful, high-resolution movies. And what you're looking at is each layer of the cornea. We're going 2 microns at a time into the cornea. We start at the surface and go deep. And I can pause it at any moment and show you each layer, like this. So on your left, you see each layer of the cornea. We're looking at it at the cellular level. We can actually see the shape of each of those cells. And these are normal. Now here, I took a group of patients with severe dry eye. You can see all those microscopic scratches highlighted with that dye. And we see changes in the way the cells look on the scan, but also look here. These are normal nerves of the cornea, these white lines. This is a totally normal eye on the bottom left here. And this is an eye that has been severely affected by dry eye. You can see one little thin nerve. It doesn't look like the maybe roots of a tree like this, but only one little thin one. And all these little spidery looking things are inflammatory cells. So I do get this test for some of my more severe patients, and they do like to see what's going on in their eye at the cellular level. Okay, so let's move on to our third question, which is what causes dry eye? That's a big question. And I cannot answer it completely today, but I want to give you some basis for understanding how we think about it. So dry eye is not one entity. It is a group of diseases. And I don't want you to try to understand all of the different causes, but at least look at in red here. Our two major divisions are to think about, is dry eye in this patient an aqueous deficiency or is it an evaporative problem? So making it really simple, I'm saying, are you missing or you have a problem with the watery portion, or are you missing or having a problem with the oily portion? So there's some patients that have both. But if you are a dry eye patient, I encourage you to try to understand where you fall in these categorizations so that you then understand what you should do about it. Okay, so I also want to show you this slide, that there are so many secondary causes of dry eye. In other words, there is something else going on with you, and dry eye just happens to be a symptom of that disease or a side effect of that medication. So when you go to see your eye care provider, please don't make an assumption that they don't care about all your other health problems. So let them know what medications you're taking, even if you don't think it's related. Oh, I didn't think I needed to tell you about the medication I'm taking for my sinus because it didn't have anything to do with my eyes. Or, oh, I didn't think you needed to know about my arthritis. Why is my arthritis related to my eyes? You know, you're not looking at my hands. These are all related things. So I encourage you to share your medical history with your eye care provider, because sometimes you can easily find out, oh, it's this, allergy medicine that you're taking that's drying your eyes out. Maybe we think about switching it to something else, for example. Okay, so Sjogren's syndrome is one of the big causes of aqueous deficiency. And if you have Sjogren's syndrome, you already know this, but for those of you who haven't heard of Sjogren's syndrome, it is an autoimmune disease that attacks the tear glands and salivary glands. And therefore, the most common classic symptoms of Sjogren's syndrome are dry eyes and dry mouth. And they don't always have to go together. So you can have really severe dry mouth and kind of mild dry eye, or the opposite. You can have really severe dry eye and the dry mouth is not that bad. You can have the right eye much worse than the left eye, and then the dry mouth is like in the middle. Any of those are possibilities. And there's a difference between primary Sjogren's syndrome and secondary Sjogren's syndrome, and it basically means that patients who already have another autoimmune disease, another rheumatologic disease with Sjogren's, we call that secondary Sjogren's. So sometimes I, as the ophthalmologist, I will ask the patient, do you have dry mouth symptoms? And if what I'm seeing on the eye and the fact that they have dry mouth makes me suspicious for Sjogren's syndrome, but they don't, say, already carry a diagnosis of rheumatoid arthritis or scleroderma or lupus or some other autoimmune disease, I might actually pursue a workup for Sjogren's syndrome. And that involves blood tests and some other types of tests. Okay, so this is a question I get a lot. Does computer work cause dry eye? So a lot of people think that, they sit in front of a computer all day and they seem to have a lot of burning and soreness. And by the time they get home from work, they just can't even keep their eyes open anymore. So is it the computer that is causing the dry eye? So let me put it another way. It doesn't have to be computer. It could be you staring at a television screen or reading a book for hours or looking at your phone for hours. Anytime you are looking at one thing, one distance, and really paying a lot of attention, concentrating on looking at that thing for a long period of time, just like the gentleman in this picture, you're gonna be staring at that computer screen. You're concentrating, you don't wanna miss anything. Naturally, your blink rate, that's maybe normally once every 10 seconds, just subconsciously, your blink rate slows down. So what does that mean? That means that if a normal person's tears should stay stable for 10 seconds before they start evaporating into the air, if you're keeping your eyes open for longer than 10 seconds, then most likely towards the end of that, before the next blink, your tears are already evaporating off the surface of your eye. And if you already started with some dryness, or if you're working in a dry environment, like the fan is blowing, the air conditioning is on, the heat is on, and a lot of office buildings are like that, then that can make things a lot worse. So here are my tips for if this sounds just like your situation. So put a little bottle of artificial tear right by your desk. And whenever you feel burning, stinging, dry feeling, go ahead and put one. And maybe if you're having this problem very severely, you don't even want to wait till you feel like that. Maybe you want to set a timer. You can set it on your phone, on your computer, that every however many hours you go ahead and put one. And if that's not good enough, maybe you want to take some breaks. Okay, so some patients, I tell them, put a timer on your phone. Every 30 minutes, you're going to take a break. I don't mean you can't work anymore or you're going to leave your office. That's not what I mean. I mean, every 30 minutes, maybe you take a 90-second break. Maybe you close your eyes. Maybe you go for a walk. Maybe you go to the window and look outside. So you're looking at something else. And naturally, when you're not looking at that screen anymore, you will blink naturally, and that will spread a nice fresh layer of tears across the eye. If you add to that, adding 1 drop of artificial tear, I think that would really help. And if you can work in a relatively enclosed space, you can also put a humidifier right next to that screen so that it humidifies the air that is between your face and the computer screen, and that will slow down the evaporation of tears off the surface of your eye. How about weather? Does cold weather cause dry eye? Does hot weather cause dry eye? It's not so much the weather that causes it, but if only cold weather caused dry eye, then we wouldn't have any patients with dry eye in Southern California, right? So weather isn't the only factor here, but anytime the humidity is low, the same problem is going to happen, that your tears are going to evaporate off the eye. And we don't like the feeling of cold or dry or air blowing across the surface of the eye. It does make the tears evaporate off the surface. Okay, let's move on to, this is a big topic, and so I want to spend some more time on this. What is meibomian gland disease? So previously I showed you some pictures of those meibomian gland openings, right? And I told you that it should come out looking like olive oil. But you see in this case, this looks really thick and white, and this is the one that looks like toothpaste. You see this little, kind of has like a little worm shape, so solid that it's coming out looking like the toothpaste that comes out of your toothpaste holder. So we want this. We want that layer of oil to look like this olive oil. But if you've got butter, it's not going to work very well. So to bring that point home, I filled these 2 glasses with water, and I put oil, olive oil, on in this cup, and I cut up little pieces of butter and put them here. So what's the difference? So here you have a uniform, smooth layer of olive oil that sits on top of the water. There's not any area, surface area of the water exposed to the air. Whereas here, you just have random chunks sitting on top of the water, and you have some areas of water that are exposed to air. Furthermore, I put this on top of a piece of paper so I could show you. If you had to choose between reading through here or reading through here, obviously you would choose this, right? And today I was thinking about this. I was in surgery this morning with one of my residents, and one of the patients had tears that, I mean, this is an exaggeration, but like looked like this. Like you could see the oily debris on the tear film. And just like it impedes your view out of the eye, it also impedes our view in. So especially if you're going to have cataract surgery or any surgery in the eye, you really want to address your dry eye problems before. Okay, but what if you actually make normal tears, your eye is creating them normally, the lid margin is nice and clean, but you have something wrong with the eyelid and doesn't distribute the tears properly. You have a problem closing the eye, or you have a problem blinking. This can cause major problems. So this eye is of a woman who had a brain tumor, and she had surgery and she's fine now. But that surgery both saved her life and damaged the nerve that controls that side of the face. So the eye can't close, her cheek is fallen, she can't smile on that side. If this sounds familiar, it's Bell's palsy is also another syndrome with that facial droop and the eye can't close. So if the eye can't close, then the lid cannot distribute the tears across the surface of the eye. So what happened to this woman is, you can kind of see right here, there's like a little reflection there. She actually had to have a gold weight placed surgically into the eyelid to weigh it down to try to help her close the eye. And you can see right here, there's a grayish spot. So what happened is the eyelid does cover the upper part of the cornea, but this area of the cornea is most exposed to air all the time. And if this gets so dried out that all the epithelial cells fall off, you can have major problems. And she has a scar from like an infection that happened. Now, this gentleman had a tumor on his upper eyelid, and the tumor was excised, so he's okay now from that point of view, but he's missing a chunk of eyelid. And so the eye is not going to be able to close. And if that is not addressed, this eye is going to dry out and have major problems. We're going to come back to this gentleman later. Another reason could be that as we age, unfortunately, we lose elasticity in the skin, and that affects the eyelid too. So you can see there's like a droopy sagginess to this eyelid. And when this gentleman tries to blink, it just doesn't, the lids don't meet. Now, if I ask him to blink and he thinks about it, and he squeezes the eyes together, and they will come together. But you can't be thinking about every single blink every waking minute of the day. And we blink multiple times per minute. So for the most part, what's happening is there's a blink that is leaving this area exposed. And so what will happen is the part of the eye that gets exposed gets dried out, and the part of the eye on the top that's covered is okay. So there's another lecture coming up in this series by one of my colleagues called Sags and Bags, where she'll talk about how we fix this. And another reason that people don't close the eye well is, especially I see it a lot here in Southern California, is too much cosmetic surgery, and then they look really wide awake, but the eyes don't close all the way. And this is also a problem, okay? So again, you can make normal tears, but if the eyelids don't distribute the tears properly, you can have a problem. So what is the treatment for dry eye? This is a big question without a simple answer, because there's so many treatment options, and there isn't one perfect treatment that works perfectly for everyone, and that alone. I want you to think more about this like it's a menu, and you need to choose things off the menu that work for you. So there should be a personalized treatment for each patient depending on their diagnosis, the severity, their lifestyle. And these treatment options that I've written here, we're not even going to have time to go through all of them. But I'll show you this handout, which is something that we give our patients in the office. It's a two-sided handout, and it looks really busy. But I'm not saying that we give this treatment to everybody. I circle or check off which things I want the patient to do. And sometimes I want the patient to do multiple things. Sometimes the patient comes in and I'm shocked that they have such severe dry eye and they've basically never been treated. And I tell them, I'm going to give you some homework to do. Take this paper and I want you to do this, this, this. And you're not going to feel 100% better. But I want you to start off doing these things. And then next time you come back, I'm going to see how you responded. And then we're going to add some more things. And it's going to seem like I'm giving you a lot to do. We got to get you back on track. And then we can find a maintenance that's easy for you, and you can continue to do that into the future. So it's a personalized treatment, and I'm going to talk about a lot of different things today, and whether that is right for you, you have to determine that with your doctor. But I just give you kind of an overview of how I think about treatment strategies in general. So I would say the most important thing is this: to address the underlying pathology. What is the root of your dry eye? We got to get to the root of the problem, not just cover up the symptoms. So if that is an eyelid closure problem, then we need to address that. If that is a tear gland blockage problem, then we need to address that. If it is an evaporative problem, we need to address that. So whatever it is that is your problem, that's how we treat it. But I can give you some general guidelines. So I'm sure you all don't even need me to explain the artificial tears are a treatment for dry eyes. It is basically the mainstay of therapy for dry eyes. And I purposefully did not put on this slide specific brands because there are too many. And I'm often asked, well, doctor, just tell me what's the best one and I'll go buy that. There isn't a best one that's better than all the rest that's the best for everyone. I don't own stock in any of them, so I don't have any favorites, but I want to give you some general guidelines on what to look for when you go to look for your artificial tears. So you could go to your local CVS or Walgreens and you'll be inundated with choices. There's just so many on the market right now. So I want to give you some little tips on how to choose the right one for you. Okay, so the first thing I want you to know is buy things that are moisturizing drops, artificial tears. Don't go for the medicated drops. You don't need the things that say get the red out or for styes or for itchy eyes or for allergy. You don't need that. They're just artificial tears, basically salt in water, okay? And don't read what the bottle says about whether it contains preservatives or not. This is what I want to teach you. You see this bottle here, all these bottles have a twist on cap. You can twist it on, you can twist it off. In your mind, just think about it like this. If I put raw milk, unpasteurized raw milk into this bottle, and I put that bottle on the table with an expiration of 1 year, would you drink that milk even next month, even though the expiration is in a year? No way, right? So that has to have preservatives in it. Whereas this kind of packaging, the individually packaged little vials, each of them has maybe about 6 drops inside, and they're supposed to be for single use. I mean, you can stretch it for a full day, actually. Those don't contain preservatives. You take the top off, you use the drops that day, and the next day you don't use them anymore. These are preservative free, okay? So the other differences, you would probably need to try different brands to see which one you like best. The only other factor I think you should take into consideration is the viscosity of the drop. In other words, how thick or thin is that drop? And my general guidelines are like this. The thicker the drop is, with the extreme would be gel or ointment. Those are the thickest. Those stick around a lot longer. They don't evaporate into the air as fast, especially the really thick ointments that are like almost like petroleum jelly. They'll last for hours, right? So you get relief for a lot longer because it'll stay on your eye for longer. But the thickness of that drop will blur your vision. So if you put petroleum jelly in your eye, you can't read, right? So generally speaking, what I recommend is get the drops for the daytime. And you might want to keep on hand some thicker drops for times when you're not reading, you're not driving, you're just at home lounging. You don't need to have, perfect vision. And when you're really feeling bad, you can grab the thicker ones. And then you save the gel and the ointment for when you're asleep. So last thing you do before you close your eyes and go to sleep is put the ointment in. That way it's lubricating your eyes all night long when you don't have a chance to put the drops every so often. Okay, and for the most part, this works for pretty much every kind of dry eye because you're just supplementing. You're acknowledging that you have a lack of normal tears, whether that's because of aqueous deficiency or lipid deficiency. By the way, they now have commercially available 2 or 3 types of drops that are specific for lipid deficiency. And they'll contain either omega-3 or flax, or they'll say for MGD on it. Either way, the concept is the same. Your tears aren't functioning normally, let's supplement with artificial tears. But again, artificial tears are basically just salt and water. They don't have the biological properties that your normal natural tears have to protect you for inflammation and infection, okay? So in some cases, using artificial tears alone doesn't work. So here's a little cute video of my daughter. So let's say this bathtub is completely empty. We want to fill it with some water, and we're just filling it with like half a cup of water at a time, right? So there's some patients that come to me and they say, oh, I've tried artificial tears. They didn't work. Well, if you have very, very severe dry eye and you're only using the artificial tears when you feel absolutely horrible, you wait until you feel like that, and you're only doing it like once a day, it's not enough. You got to do more than that. Okay, so the next treatment I want to talk about is one that many patients have already heard about, which is these anti-inflammatory medications. So now we have 3 anti-inflammatory medications that don't contain steroid on the market. Okay, I want to differentiate that. So steroids are very effective for short-term use. You put the steroid in, it decreases inflammation, but it's not good to use steroid for a long time. And it actually can be very dangerous if you're not monitored properly, or you get a lot of side effects if you use it long term. So we don't like to prescribe steroids to treat dry eye for a long period of time. So we usually like to transition the patient to something like one of these medications if you are a patient who has inflammatory mediated dry eye. And remember, I showed you there's a test for that. So of these 3, I put them in order of when they were FDA approved. So Restasis has been around the longest, then Xiidra, and more recently, Cequa came on the market. Actually, Restasis and Cequa are both the same active ingredient, cyclosporin, but in different sort of formulation and different percentages. But the idea is the same, is that these are medications that reduce inflammation without steroid, but they don't take effect right away. So I have had many patients say, oh, I tried, for a week and I didn't feel better. Like I put it in my eye and it burned and I didn't feel any better. So one thing is, it is known that these medications burn upon application. That is a known side effect. And particularly when you're starting with really inflamed eyes, they can, very severely dry eyes, they can burn even more. But you'd have to use these drops consistently twice a day, every day for at least a month, maybe up to 2 months before you even feel a difference. You see, the packaging is kind of maybe confuses patients because it looks just like those preservative-free artificial tears I showed you earlier, but it's a very different concept. So this drop, the drop you put now is not making you feel better right now. You're putting this drop for long-term control. Whereas the artificial tears, is supplementing the tear at the time, okay? So it's important to differentiate that. And, if you had burning with Restasis, don't give up. Maybe you could tolerate one of the others better. There are some easy lifestyle changes that one could make. Some people take supplements like omega-3 fatty acids or flaxseed or fish oil. And if you want to do that, that's good. Or, you don't have to take them as pills. You can just eat them naturally as foods. So social changes, like particularly trying to avoid staring at the computer or the TV for long periods of time without taking a break. We talked about that already. Contact lens wear is an important one. So if you are going to wear contact lenses and you have a dry eye problem, you want to use rewetting drops, but also just try not to wear them 16, 18 hours a day. Try to limit your wear if you really have to. We talked about some environmental changes like using a humidifier. Try not to sit right next to a fan or air conditioner for long periods of time. And the big one is this lid hygiene. So we'll talk more in detail about this eyelid scrubs and massage and warm compresses to the eyelids. But I tell patients, make it part of your routine. Get into the habit of treating your dry eye just like you do, brush your teeth every day, do your lid hygiene twice a day. So let's get into the details of that. So what about this warm compresses? So in its simplest form, all you have to do is take a towel, a clean towel, and put it in hot water. You want it to be hot or at least warm, not so hot that you're going to burn your skin. Because of course, the eyelid skin is very thin and very delicate. So you don't want to burn yourself, but you do want the towel to be hot or warm, and you do want a little steam coming out. So it's not cold, okay? So a lot of people get confused of when to use cold compresses, when to use warm compresses. But in this circumstance, I really want you to use warm compresses. And we're going to close our eyes. I'm going to put that warm towel over our closed eyes and just relax for 10 minutes. Now, if that towel loses its heat in less than 10 minutes, you can stick it back in the microwave for a very brief moment. I mean, it depends on the strength of your microwave, but sometimes like 1 or 2 seconds is plenty, and put it right back, okay? And there are fancy things that you can buy to do this. And if you want to do that, that's great. But you don't have to spend a lot of money to do this. You can just use a towel and warm water, okay? But why are we doing this? So remember I showed you this before, that you want olive oil, but some of you have butter. So how can I make that butter more like the olive oil? You heat it, right? So that's a simple concept. And that is why we're doing the warm compress, but also the warmth opens up the opening of the ducts that bring the tears out. So it's doing both things. The warm compresses also loosen up all of that dandruff-like material on the eyelashes and make it easier to wash off, which brings me to lid scrubs. So we used to recommend to patients just put a few drops of baby shampoo into water, dilute it, put on a Q-tip, and use that to wash the base of the eyelash, just like you would shampoo your hair, but not shampooing the end of your hair. You have dandruff, you want to get at the scalp. So it's the same concept. Well, we recommended baby shampoo for years and years. And now actually there's so many commercial products that you can buy either over the counter or Avenovas by prescription. And these make it a lot easier if you don't want to do the baby shampoo. So some of them come in a foam pump, and you pump some foam on your hand, like it looks like mousse, and you get it on your fingertips. You can do it in the shower, and you just massage right at the base of the eyelash, okay? Or they come in these pre-moistened pads, kind of like for removing eye makeup, okay? And why do we want to do this? Because we want to get all of that debris and inflammatory material off of the root of the lash, which is really close to where the glands open up. Because if you leave that over time, you're going to get inflammation on the lid margin. It's going to affect your ability to create normal tears, okay? But if that wasn't reason enough for you, I want you to look at this picture. So here are the eyelashes. And if you're only looking at the ends of the lash, it looks pretty good. But look at the base of the lash where it comes out of the skin. Do you kind of see that there's like a little sleeve, like a cuff around where the lash is exiting? Okay, so that can occur because you have these little friends living in your eyelash follicles, these little mites, and they leave their waste products right there at the base of the lash. And that's usually what that looks like. And if that didn't scare you enough, what we do to diagnose this when we think we see it is we pluck a lash and we can see the little critters moving under the microscope. So this is not something you can see with the naked eye. This is this video was taken through a small microscope after a lash was plucked, and this is the little friend that you'll see. So if you do eyelid scrubs with tea tree oil, that will help get rid of these guys. Okay, so let's say you're doing all these things and you're trying your best to get rid of all of that debris, and it's either too frustrating for you, or you're not getting it all off. There is a procedure for, and you can think of it like you go into the dentist for a deep cleaning, right? Where we use this, there's a little sponge at the tip of this rotating device, and we can use it to, the doctor can manually use that to remove all of that debris at the base of the lash, okay? That can be very helpful. What if that meibomian gland is still excreting some very thick material? We can help you out by manually expressing. Okay, so here I'm just doing it with 2 Q-tips, and sometimes I do this kind of in the clinic just to see how hard do I have to press to get it to come out, because this is not something I want you to do at home by any means. Please do not try doing this on yourself at home. I do this just to see how hard I need to press to get it to come out, and sometimes these patients feel so much better after I've done it that we do offer this as a procedure in the office, where we use a device to squeeze the glands for you, okay? But actually, another way to do it is to apply heat as well. So we have this device in our office that it's like these little stickers, and that you control it. The patient can control the heat themselves. And you sit there for like 30 minutes while it has a nice heat and like gentle vibration there. And then we go in with our instruments, and the oil is now nice and soft, and we can squeeze it out even better. But we also have this other device in the office called LipiFlow, and this device by itself does both the heat and application of massage. And sometimes in one, you can just do one treatment and it can last maybe up to a year. This is an in-office procedure that we do. Okay. So let's move on to one other very common treatment, but I thought maybe I would just for fun give you a little quiz. So literally, this is a question that I ask patients in the office. Before taking a bath, what is the first thing you do before turning on the faucet? Okay, just bear with me, I'm going somewhere with this, but I'm asking a serious question. And no, this is not a trick question. So again, we're going to take a bath, not a shower. So before you turn on the faucet to let the water out of the faucet, what is the first thing you do before you take a bath? So get your answer in your head, because for some reason, in all my years of practice, I've only had one patient answer this question correctly. I don't understand why. And I will just leave this here on the screen for your entertainment of the various answers I have gotten to this question. And I told you, it's not a trick question, so I will let my son, who's 3 years old, answer. Okay, so it's as simple as that. Before you start taking a bath, you put the stopper in the drain, right? Because the concept is just this. If you think you want to turn the water all the way off, you are expecting a heavy stream of water, but you just get a little drip, drip, drip. Okay, so this is what's happening in dry eye. You think you want a normal, healthy amount of tears, but your eye is not making the amount of tears you expect. And yet the drain is wide open. So all the little amount of precious tears your eye is naturally making are going down the drain. Okay, so remember I told you that we have this tear duct by the side of the nose. It's like the gutter that takes the rainwater away. Well, in this situation, we want to keep that moisture. Okay, so how do we do this? So this is called punctal occlusion. We usually do this with punctal plugs. So again, the tears normally move from this corner because the tear duct is over here. It's creating the tears and moving across in this direction towards the nose. And you've got these two holes, one in each lid, and the extra tears drain into this duct, which then drain into the nose, and then from there into the back of the throat, and you swallow them. Okay, your nose, your throat don't need that moisture. It's just a way for the tears to exit. But when your eye is not creating enough of the watery portion of the tears and you just don't have enough volume of tear, you just don't have enough tears, you want to keep all of those tears in the eye. So what we do is we block that drainage pathway. And how do we do that? Well, there are a couple of ways, but the most common way is called punctal plugs. So it's literally a little stopper that goes into the drain. And when I tell patients about this, they get scared and they think that there's some major surgery that I want to do on them. And they are asking me, do they need to go under general anesthesia for it? It is an in-office procedure. And to show you how simple the procedure is, I made this little video to show you how it's done. And I have done it on myself looking in the mirror, but it's much easier looking in the microscope. So you saw that little hole. That little hole is the hole to the tear duct, and that little purple thing is the plug. Okay, and that's all it is. So we generally start with the lower lid first, and the patient didn't feel it. The area is anesthetized. We just use topical anesthetic to numb that area. I'll see it one more time. So that area is numb. He's not feeling it, and we just insert the plug into the hole. And this particular plug that I'm putting in this video is a collagen plug. It is dissolvable. So this is a temporary measure for this particular person. This is only going to last 1 to 3 months, perhaps. But it's a good choice if you've never had it before and you're scared of making the decision to go ahead and do a permanent plug. But even though we call them permanent plugs, these silicone plugs, they can stay permanently, but they have this sort of rim at the top that sort of sits on the outside. So, and if you ever wanted it reversed, it's so simple. We just pull it out. And again, in the office, it's with just anesthetic drops. It's not a big deal. So usually the discussion about the plugs takes so much longer than actually putting the plug in. So we normally start with the lower first because you get more bang for your buck there. And if the patient wants to do the upper ones, rarely we do it. Usually you don't want to block off all the drainage because what can happen is it will work too well and you'll build up so much fluid that it's like the water overflows from the bathtub and you'll have tears that flow down your face. But for patients who have very severe dry eye, they would be ecstatic to have so many tears that there would even be a bead of tear falling down their face, even when they're watching a sad movie. It just doesn't happen for them. And in the very, very severe patients, if they've gone through punctal plugs multiple times and the punctal plugs either didn't fit or fell out or some problem and the plugs had to be replaced multiple times, there is an actually permanent procedure that can be done. But usually that's reserved for very severe patients. Okay, so I thought for the last couple of slides, I might just touch on some things that are really only for very severely affected patients. So I'll just quickly go through them because it's not for everybody, okay? So moisture chamber glasses and goggles, these are for people who either have problem closing the eyelid all the way or they have like severe evaporative problems or just any severe dry eye might benefit from this. So the idea is that the air passing by the eye is what really is irritating and evaporates the tears off the surface. So what if we blocked air from entering the eye? So these glasses sort of touch the patient's skin so that the air cannot enter from any direction. They're not really suction to the eye, so it's not as tight as, say, swimming glasses, but it should fit your face. So you really should try them on instead of just buying these glasses on the internet. But the great thing about this is, like, let's say it works too well and now it's foggy in there, or you go on a trip to a very humid place and you don't need um, to retain that much moisture. This silicone piece is actually removable. You can take it off to wash it, put it back. It's attached with little magnets. So if one day you don't need this anymore, you can just take it off and wear these as regular glasses. And you can get them in sunglasses in various different styles, okay? And then for nighttime, there are some people who wake up with really dry eyes because they don't close their eye all the way when they sleep. And that's not something they can help. Or there are some patients who wear a CPAP, like for sleep apnea, and there's air blowing towards their eye all night. They can wear goggles to sleep. And there are goggles that are specifically made for patients with dry eye. Obviously, you cannot see out of them, so it's only used for sleep, okay? There are also some oral medications or pills that can be prescribed for severe dry eye, but these will not only increase tear production, they will also increase saliva production and can also make the skin feel more moist, or if like you feel like you're sweating a lot. So some people don't like those other effects, but particularly patients who have Sjogren's syndrome, they're already dry. They have dry eye, they have dry mouth, they have dry skin. Those patients do better with these. And has anyone ever heard of serum tears or autologous serum or serum drops? So the idea behind this is that while artificial tears are readily available and they're easy to get and they supplement the lack of normal tears that your eye is missing, the artificial tears will never have the biological properties that normal healthy tears have in being able to help promote regeneration of the corneal epithelium, or having growth factors or anti-inflammatory or antimicrobial properties. So there is this idea that, well, what if we just took some other biological fluid and tried to put it on the eye? So one idea is to use the patient's own blood. So, but you see that the drops are not red. So what happens is somebody comes to your house, they draw the blood from your arm, and then they put it in a centrifuge and spin down the red blood cells. So what's left is called serum, and that's not red. It's like this transparent yellowish fluid. And so that can be put into eyedropper bottles and given to the patient to use on their eye. And they usually use them 4 times a day. And it can be given straight, like 100% serum, or it can be diluted to 25%. And what happens is you get all these bottles and you put one of them in the fridge and you use that while all the other ones go into the freezer. So hopefully one blood draw lasts you quite a while. So again, this is reserved for very severe patients. I mentioned earlier that contact lenses, you should try to avoid them in dry eye, or at least reduce the frequency of wear. But here I'm actually recommending a particular kind of contact lens for mostly severe dry eye. And this is a very special kind of contact lens. Most people have never heard of it. It is called a scleral lens. So all other kinds of contact lenses sit on the cornea. And again, that's the area that is most vulnerable to being dry, right? So we don't want the cornea to be rubbing against this contact lens all day long. Well, this particular contact lens is very, very good for dry eye, actually, because it doesn't touch the cornea at all. In fact, it vaults in front of the cornea. And the space in between the lens and the cornea is filled with fluid. So I tell patients it's like your eyeballs taking a bath all day. And truly, for those patients with really severe dry eye, sometimes this is just their saving grace. They feel like, oh my gosh, I put it on, I've never felt better in my life. Let me show you how it works. So it's almost like it's a big giant contact lens, like a bowl, and you fill it with this fluid. And then you have to put your face downwards as you insert the contact lens. And so that you don't get bubbles stuck in it or the fluid falls out. And this is what it ends up looking like. So the part of the eye it's actually touching is the white part of the eye, the sclera, and it's not touching the cornea at all. The only thing touching the cornea is the fluid you put in there. So people with severe dry eye actually love this. And it has to be fit by a particular kind of optometrist. And so do you remember there was that patient I mentioned earlier who had a tumor on his upper eyelid and he had the tumor removed? He's waiting to get the eyelid reconstructed by the plastic surgeon. But in the meantime, if the eyeball is not addressed, that eye is going to dry out and like severe problems are going to happen. So this patient was able to get a scleral contact lens to wear in the meantime as he is about to go get his eyelid reconstructed. Okay, so just some few quick takeaway points before we get to our questions. Dry eye is a complex multifactorial disease that causes discomfort and decreases vision, and it causes all sorts of other symptoms that we talked about. Dry eye is diagnosed based on patient symptoms and examination of the tear film, eye, and eyelids. So if you have listened to this lecture and you're convinced you have dry eye, but you've never seen an eye care professional, I would highly suggest that you have the exam that we talked about. There are many causes of dry eye, and you should, if you are a dry eye patient, you should try to understand what is the cause of your dry eye. The treatment should be personalized for each patient based on the cause and severity of their dry eye. And sometimes there are different treatments for the right eye and the left eye. Sometimes it changes with time. Sometimes your treatment will work for a while and then you'll have a bad flare and you'll have to chase that to put out the fire and then go back to your maintenance. So I want to thank you for joining us and thank my two little buddies for their help in preparing this presentation. They both got a little bit wet. I hope you enjoyed those little videos, and these are our locations. If you want to come visit us, I'd be happy to see you and talk about your personal situation if you like. This is our building. So I know I talked more than an hour, but if you have any questions, I can take the questions now.
Hi, Dr. Lee. Thank you so much. That was a very informative lecture and great graphics. I think everybody got a lot out of that. There's some good questions. Some of them you may have addressed in your lecture, and I'll just quickly go through some of them. And if you can recap, if you'd answered them or address them if you have not. One of the questions was, can dry eye requiring eye drops be caused by cataract surgery?
Okay. So I don't think that cataract surgery would cause the dry eye, but I would say that dry eye definitely needs to be treated before you go to cataract surgery, because the cataract surgery, you'll do better, you'll be more successful with your outcome if you treat the dry eye well. And you may not even realize you have dry eye, and then you have cataract surgery and all the drops that you have to go through, and the recovery from that cataract surgery may bring out those problems more. So I really work a lot with my patients who want cataract surgery but look like they have dry eye. Some of them don't realize they have it. They just thought that those sensations were normal, or they don't happen to have not a lot of symptoms. But I'm a real stickler about that. I give them homework to do to like prepare them. And I have canceled patients. I have a patient that came from out of state to have cataract surgery with me. The first time I met him, I said, you got to get this dry eye under control. So I'm going to send you back home and you're going to put artificial tears every 2 hours. You're going to do this. And he came back for his cataract surgery, and I saw him like a week before the scheduled surgery. I looked at his eye. I said, have you been doing the things I said? He said, I didn't really think I needed to, because I didn't really think that I was all that bad. I don't really have that many symptoms. And I said, well, I'm not doing your surgery because you don't look like you're ready. Okay, sorry.
That's okay. So you've kind of addressed this when with all the great information about the artificial tears, but someone asked if using artificial tears will actually make your eyes produce less tears than normal.
No, I don't think that will happen. So if you think about it, you're a normal person, your eye is making tears all the time, right? Without you thinking about it. All day, all night, is constantly producing a small amount of tears. If you didn't produce any tears and you just wanted to supplement with artificial tears, there's no way your hands could apply tears at the rate, the normal rate that your eyes would normally be producing. Furthermore, that feedback mechanism that tells your eye it needs tears, it's not really controlled that way. It's more like the eye should have some sensation that it is dry, especially if there are those little microscopic scratches I showed you, and that would then tell the tear gland to produce more tears. So I don't think you need to be really worried about this, but I also don't think that if you're even asking this question that you're putting too many tears, okay? So the only time I think that it might be not a good idea to put too many is like, let's say you have mild dry eye and you're putting tears, artificial tears, like every hour. Maybe that's a little too much, especially if you're putting the preservative containing tears. The normal tears that your healthy eye is making has all those biological properties that the artificial tears don't. So in that case where you're a mild patient and you're like flooding your eyes with too much, you might be washing those away. That's maybe my only comment about that.
Great. You did give some information about using a gel or something thicker at night, but one of our guests asked, said that his dry eyes only seem to manifest at night while sleeping, and asked for you to comment more probably about that only happening at night versus the recommendation for the gel or the thicker drops that you already gave.
Okay, so if you're feeling like your eyes are more dry at night, and it's even waking you up from sleep, you might want to have the doctor see if your eyes don't close all the way. That might be the issue. So the reason why I recommend the gel or the ointment is specifically because it doesn't evaporate that fast. And I don't want you to wake up in the middle of the night and disrupt your sleep just to put the gel. So you might want to look into, have somebody take a look at you when you're asleep and see maybe, not like you're wide open like this, but maybe the lid isn't coming all the way down. And I'm looking at your comments. I just see the yellow lines too. I must have done that by accident. I don't know how to get rid of it. I'm sorry.
Another question is, do medications such as Lumigan cause dry eyes as a side effect?
Okay, so a lot of medications can exacerbate dry eye. Many. There are, pills that you take that can do it. All kinds of glaucoma drops and all kinds of just drops in general. Like there is toxicity from lots of those drops. There's toxicity from the preservatives in the drops. But if you are a glaucoma patient and you have to take glaucoma drops so that you don't lose vision from your glaucoma, that's usually something that we have to accept, short of you having some kind of surgical procedure or laser procedure to lower your pressure so that you can get away from the drops. Sometimes this is just something unavoidable. Sometimes we can try to minimize the effect by prescribing preservative-free formulations of those drops, if it's even available.
Great. So somebody else asked how they can tell if episodes of irritation and tearing that stop when their face is washed come from dry eyes or allergies.
So yes, I think the symptoms can really overlap a lot and the two can interplay quite a bit. But there are signs that we can see on exam that would lead us more towards allergy. Also, I think if you can identify that you are allergic to a particular substance, or maybe an environmental allergen, or some kind of perfume or detergent, or based on when you get the symptoms, that might help make the diagnosis of allergy more plausible than dry eye. But the two interplay quite a bit also.
Great. Somebody asked, for teens that are presenting with possible meibomian gland disease, they ask if that can be a side effect or caused by Accutane.
Interesting. So teenagers can get a lot of meibomian gland disease, just like acne. So the meibomian glands are the lipid or oil secreting glands in the eyelid. And they're very, very similar to the oil secreting glands in the skin. So the two things like acne and meibomian gland disease can happen together. And by the way, I forgot to say this earlier, but if a meibomian gland is blocked and it doesn't become unblocked, and the blockage is so severe that the gland is still making the oil, but it just can't get out because it's blocked, that will eventually become a sty. So the warm compresses work too. So I think that it is very possible that this teenager has both things. And so the Accutane can cause dry eye. That is also true. This is a multifaceted issue. So I would suggest that that person be evaluated to look at their glands.
Great. It's 8:30. We'll just take one or two more questions. One of them is, do you recommend Newlid's dry eye device? This person's doctor wants them to use it 2 times a day.
So I think we don't have this particular device, so I can't comment on any personal experience. But sometimes there are new devices for dry eye that come out all the time. And like I said before, the treatment should be personalized to you. So I think that if your doctor personally recommended to you, I think it's worth you trying. And sometimes you try something and it doesn't work. A lot of times I will prescribe, for example, this is a common one. I'll prescribe Restasis and it'll cause burning. Well, it's a known side effect, but I don't know who's going to have that side effect until you try. I also, didn't have time to talk about all these like new kinds of treatments and devices, but there are new things coming out all the time. And dry eye is a big topic that pharmaceutical companies are very interested in. So there's new things coming out all the time that, so you look out for clinical trials if you're interested in that kind of thing. They're always looking for patients when they're trying to approve new products.
Great. We'll wrap it up with one quick last question. Somebody wants to know if you can mix using a gel and artificial tears by day.
Definitely. In fact, we usually recommend that. That's a very common thing that we recommend. So the artificial tears during the day, because you can see through them, they're more liquidy, so they won't blur the vision, but that means you have to use them more frequently. But since you're awake, you could do that. Whereas at night, we don't want you to wake up in the middle of the night. We want you to use something that's longer lasting. So, and you're not reading, you're not watching TV when you're sleeping. So the vision aspect of it doesn't quite matter so much. So that is very, very common that we will recommend that combination. Yes. But which artificial tear and which gel you can experiment yourself. There's so many. There's a lot on the market that you can try.
Great. Well, it is past 8:30 now. Thank you so much, Dr. Lee. That was fabulous. For all of you who are still hanging in there, we are recording this lecture, and it takes us a little bit of time to get it edited and posted on our website. And we will send a link out to everybody who had registered. We ask your forgiveness for the technical difficulties we've had. We used Zoom registration link for the first time, and it did pose some problems. So we apologize and thank you for your patience, and hope to get that worked out before the next lecture. There are 7 more coming up in 2021, and we hope to see you back at some of those. So thank you very much for joining us, and stay safe, everyone.
Thank you, Dr. Lee. Have a good evening.
I'm so sorry about these yellow lines. I saw that and I was like, I don't know how I did that. That was when I was trying to.
I think that tends to happen when we annotate